To start off our interview, how would you describe your journey through the medical profession?
Well, I'd say it wasn't my idea, the journey. It was my father's idea.
Hmm.
I was off in graduate school getting a master's degree in English literature at UVA. And my father, who's Persian and comes from the Ayatollah school of parenting, basically stopped talking to me until I would agree to go to medical school. So
Wow.
it really was his idea. And he was a trained physician in Iran and came to America in the 50s and was one of the founding fathers of modern immunology. So had high hopes and dreams for me as to become a physician as well. And eventually I acceded to his wishes. I went to med school at the University of Pennsylvania, came out to San Francisco in 1986, knowing that the AIDS crisis was unfolding, and did 3 years of training in internal medicine at Mount Zion Hospital, right in the teeth of the worst of the AIDS pandemic.
Wow.
Started a research program on June 20th, 1989, primarily around HIV, also looking at treatments for CMV, cytomegalovirus being a herpes virus. There are 8 of them that was causing blindness in folks with HIV, as well as a lethal virus in transplant patients. And then there was a giant sucking sound that's continued over the last 31 years, where Quest Research, at first as part of Mount Zion, then part of UCSF, and then after 1996 as an independent, sort of privately owned research program. It's a bit of an anomaly. We've been involved with over 300 clinical studies in patients now with HIV, CMV, herpes. We did the papilloma vaccines, hepatitis B and C. We did influenza drugs. We do a lot of gene therapy. We do work in cancer. And I've been the principal investigator on about 300 studies, as I said. And then the reason we're doing this interview today is that one of our HIV drugs called leronlimab, a drug that we're also looking at for the treatment of cancer, we have just announced on Tuesday is, in my view, the first real treatment we have for COVID-19.
That's wonderful. We have several questions about leronlimab as well, and we'll be getting to those questions eventually, but I'd like to pass the mic over to Fiza. Thank you so much.
Yep.
How would you describe your current job?
Well, I wear a number of hats. First and foremost, I see myself as a patient advocate, unpaid, but nonetheless, my primary, the reason Quest has worked for these past 31 years is in part, my mother was a survivor of the Holocaust, and I have always gravitated toward patient advocacy, and certainly in interacting with pharmaceutical companies, I see that as one of my key roles, is to make sure whatever we're doing in the research realm, that patients' interests are kept in the center of the equation. I always tell sponsors, if we keep patients in the middle of the equation, we won't make a mistake. So patient advocate number one. I'm the medical director, CEO of Quest Clinical Research, which is a clinical virology research program, now also involved with cancer. I am the chief science advisor for a company called Cytodyne, which Quest has partnered with for the last decade to develop their drug for HIV, and we've now entered the COVID space, and so I've been helping Cytodyne navigate COVID-19, including their FDA communications. And then I'm also the interim chief medical officer of a company called Virion that has a T-cell based immunotherapy that we're looking at for hepatitis B and other infections and cancers. So I wear a number of hats. but the heart and soul is to be a patient advocate as we enroll clinical studies to identify which drugs are working to help patients with various infections.
Thank you. I will pass it on to Crystal.
Okay. How has work changed for you since COVID-19 became a global pandemic?
Yeah. Well, Quest was bouncing along, and we were quite busy, and starting to look closely at the use of leronlimab for the treatment of cancer, specifically CCR5 positive cancers that either express that marker on the tumor itself or have a high level of expression in the surrounding cellular infiltrate in the tumor microenvironment. And we thought we were seeing a positive signal, and then COVID-19 hit. Obviously, a lot of everything came to a halt. A lot of our research studies came to a halt, not because we had a problem so much here in San Francisco, but because our sponsors are national and they were shutting down. But we, working with Cytidine, we decided that the CCR5 mechanism could be exploited to the benefit of patients with COVID-19 possibly. And so we jumped right in. So even though a lot of our work that was going on came to a stop, there was a lot of energy that went into ramping up the COVID-19 program. And in retrospect, it was the very right decision.
Okay, thank you. I'll pass it on to Jalen.
Okay, what studies are you currently working on?
We right now have about 30 or so different studies. So in HIV, we do various treatment studies of new therapies. We collaborate with a variety of sponsors on HIV cure projects. For example, identifying patients who are elite controllers, individuals who control the virus themselves without needing to take pharmaceuticals. And we obtain cells and tissue from them to try and understand how they're able to do that, and whether that's something that can be replicated for other individuals. A lot of new HIV novel therapies, attachment inhibitors, so new drugs. We have 3 or 4 different projects in hepatitis B. Years ago, we had done the original study of a drug called sofosbuvir, which ended up being, creating cure rates in hepatitis C of 100%. And hepatitis C was a little bit of an easier target because you don't have that intracellular reservoir of virus that, like you do with HIV or hepatitis B. But in a similar vein now, there were a lot of smart people who started in HIV and then gravitated over to hep C, and now they've moved on to hepatitis B. And so there are new classes of drugs coming along to look at the possibility of treating and curing hepatitis B. So we do 3 or 4 of those studies. We have several cancer studies, again, looking at the exploiting CCR5. And there is a video available of the proposed mechanism of action in the setting of cancer with CCR5 that I could send you the link to, and you could include if you want in this interview.
Oh yeah, that'll be great.
Yeah, that's quite interesting to see the way that the cancer cells, have evolved to figure out ways of avoiding and evading the immune system. And so, for example, one common way that you hear about on television all the time, whether you know it or not, is all these monoclonal antibodies that target something called PD-1 that are now being used successfully to treat a variety of previously untreatable cancers, including melanoma, lung cancer, colon cancer. I mean, the treatment of these cancers has been revolutionized by this antibody that targets something called PD-1. And what PD-1 is an off switch. So the immune system's job is to figure out what is self and what is not self, and to be kind and love self, and to be wary and potentially kill not self. And it's very tricky because nothing comes labeled. Everything is just sequences of amino acids in nature. And so to identify self and non-self is really one of the great miracles of life that we take for granted. And there are plenty of opportunities to get it wrong. And when the immune system gets it wrong, for example, it could go after self by mistake. That's known as autoimmune disease. And there are a whole host of them: lupus, rheumatoid arthritis, where the body is attacking self. And there are situations where you go after non-self too aggressively, and you can have asthma, allergies, hives, and then there are situations where you don't attack non-self, and that's immune deficiency, so AIDS, cancer. So it's a very tricky balance. And the way the immune system basically approaches this is to have a series of on-off switches that either turn the immune responses up or turn them down. And so you can increase the immune response or decrease it. And what cancers have learned to do, and viruses, is to exploit those on-off switches so that cancer cells actually secrete something that binds to PD-1 and turns off the immune system. And that allows the cancers to thrive and avoid the immune responses. In a similar way, the video will show you for CCR5, cancers use that CCR5 messaging, signaling, to protect themselves, to protect the tumor cells from other cells of the immune system that would be trying to kill it. So it's a way that cancer has evolved to co-opt the immune system to protect itself from other elements of the immune system. And I'd be happy to share that video with you. So the HIV, current studies are HIV and hepatitis B, cancer, a lot of HIV cure work. We have 3 or 4 gene therapy stem cell projects that are ongoing. And we do a lot of studies, about 10 studies in fatty liver. There is a epidemic of fatty liver in this country. It's become the most common cause for liver transplantation. And although we're not exactly sure what's causing it, surely it has to do with the crap that we put in our mouth and call food, and possibly related to all the sugar that's being added to everything. So that's that. We're busy.
I have to look into that more, and I'd like to pass it over to Jason.
Yeah, so another question that we have for you is, what is your objective for these 2 separate studies, which is CD10 and CD12?
I'm sorry, what was the objective of the 2 separate studies, CD10 and CD12?
Yes.
Yeah. All right. So the leronlimab is a drug that we worked on for a long time to treat HIV, and we know it works in HIV. It's not going to change the world as we know it, but the way it works is leronlimab is what's called a monoclonal antibody, meaning it's an immune protein, an antibody that binds to one thing. And in that one thing it binds to is something called CCR5. And CCR5 is a receptor on T cells. And it has a function that we're exploiting for COVID in CD10 and CD12. But the HIV mechanism of action is simply that HIV happens to use CCR5 to get inside of cells. It turns out that the plague bacteria, the black plague, plague bacillus, also use CCR5 to get inside of cells. And basically the black plague killed half of the population of Europe 600 years ago. And the people who survived the black plague happened to have a genetic mutation that they didn't have CCR5 receptors. So they were immune to the plague. And so there was a selection event in history that killed 200 million people, and a good chunk of the ones that didn't die didn't have these CCR5 receptors. So if you fast forward 500 years, we're in the middle of an AIDS pandemic or epidemic, and we notice that there's some people, some of them sex workers, who are exposed to HIV but don't get infected, and that's how the CCR5 receptor was discovered, because those people were descendants of people that survived the Black Plague. Because HIV, like the plague bacteria, just uses CCR5 as a co-receptor to get inside the cell. And leronlimab, by blocking that receptor, is an HIV antiviral that reduces viral load, et cetera. And, you know, it's fine. It's very safe. We've given it to 700 or 800 patients with HIV and have seen no safety signal. And that's very important for the COVID story. But its mechanism is based purely on blocking the receptor as a doorway for the virus to get in. But that doesn't speak to the function of CCR5 in the body, which is very different. And what CCR5 does in the body, it's kind of like the GPS system of the immune system. So it controls the movement of cells. It tells cells where they want to go and how they want to arrive. So, for example, we said in the cancer model that we were working in, the cancer cells secrete this thing called RANTES, which attracts these CCR5 positive cells, which then surround the tumor and protect it from other cells of the immune system that would try and get in and kill it. And then by triggering CCR5 on tissue macrophages, those macrophages, their polarization is altered so that instead of attacking the cancer cells, they're now helping to build blood vessels to help the cancer grow. So that's what we were looking at in cancer when COVID hit. And we realized that this movement of cells that is such a big part of COVID could be impacted by blocking CCR5. So for example, in COVID-19, there are, broadly speaking, 3 phases of the infection. Phase 1 is when you get infected by the virus. And for some people, that's all that ever happens, particularly younger people. They get infected with the virus through their nasopharynx or their oropharynx, and therefore develop a cough, sore throat, or runny nose, or they swallow the virus and they develop diarrhea, because it's all about these ACE2 receptors. And so there's a virologic phase, which is generally asymptomatic when the virus is churning up. And these young kids that they want to send back to school, these kids do not have symptoms, but they have the highest levels of viral infection. And so the idea that young kids with, snot-nosed kids running around are not spreading the virus is the most silly thing I've ever heard. But phase 1 is a virologic phase. And then the immune system responds to the virus. And as with influenza, it's the immune response that makes you sick. So it's not the virus that makes you sick, it's your response to the virus that makes you sick. And that can be, the course of normal flu. When you have a flu-like illness that lasts for 4 or 5 days, that is your immune system responding to the virus and secreting things called cytokines and chemokines and other messengers that bring antiviral cells into the site of infection and kill the virus. But it's the immune messengers, the cytokines, that are actually causing the fever, the muscle aches, the fatigue, and so on. But in COVID, there's a 3rd phase, and that is a hyperinflammatory phase. And that's where the immune response has become disordered and chaotic. And for some reason, the immune system can't clear the virus. And we know this to be true, that there are people with COVID-19 who get infected, and they, even if they get better, they keep shedding virus afterwards. So it's not a completely effective antiviral response. But so virologic phase, immunologic, hyperinflammatory, and that hyperinflammatory phase is when people are really in trouble. They end up getting intubated because their lungs are full of cells and fluid, and they can't exchange oxygen effectively. And that's when all the other bad things happen, like kidney failure, liver failure, clotting. People with COVID-19 end up with clots everywhere, including their brains. And well, so that hyperinflammatory stage is in part mediated by CCR5. The way you end up with lungs full of angry cells is that the virus, you know, maybe it came in through your nose, or maybe you inhaled it through your mouth, but I'm on a Zoom call, but it ends up in your lungs, and then the cells of your lungs get infected, and they say, hey, we're in trouble here. And they secrete this thing called Rantes. And what Rantes does is like a perfume, and it attracts these CCR5 cells of the immune system, and the lungs are saying, come to the lungs, come to our rescue, come help us, come quickly, come angrily, and ultimately come in chaos. And so people with ARDS, acute respiratory distress syndrome, which is what happens when people are having pulmonary collapse and they require the breathing tube be placed and then put on a ventilator with oxygen under positive pressure to try and force the oxygen into the arterial system. That's being mediated in part by CCR5. And so we didn't know for sure, but we thought it could work, that by blocking that messaging, we could block the chaos of the hyperinflammatory phase of COVID-19. So we proposed 2 studies to the FDA. Initially, the FDA had no idea what we were talking about, because none of what I'm telling you is established medicine here now. This is a completely new chapter in the textbook of medicine, CCR5 mediated inflammatory disease. And so there was resistance at first. They, in fact, had the whole program on clinical hold. They did not want to let Cytidine move forward with their clinical studies while they evaluated more traditional antiviral therapies, because they thought that was going to be the answer to COVID. Well, the problem with antivirals in COVID is that there isn't a virologic phase to COVID, but again, it's at a time when people don't have symptoms. So most people who are in the virologic phase of COVID don't know they're infected. So the time that an antiviral would work is a time when people don't know to take it. Now, an antiviral could work in COVID as prophylaxis. So somebody who's sick with COVID, they come into you're sharing a house with them, that would be a good time to take an antiviral to prevent infection. But once you're infected, you don't know it until your symptoms start, and by then you've moved into the immunologic phase, and viral levels are starting to come down anyway. So the antivirals don't work, but the FDA didn't know that. So they were really focused on antiviral drugs for COVID, hence remdesivir or hydroxychloroquine, which have shown little or no effect, because they're not going to. They never were going to. And the FDA didn't quite understand how blocking CCR5 would affect trafficking of cells, and that could bring balance and calm to the immune system in patients who are moving toward hyperinflammation and pneumonia. But eventually we pushed back and said, no, it's not the virus that kills you in COVID, it's the immune response. And after these last 5 months, and sort of the Holocaust that we've been through, I think you can read most of the articles now in the New York Times that are being written are talking about the cytokine storm and this disordered, chaotic immune response as the thing that's driving mortality in COVID-19. So everybody's come around. And so we had two studies in COVID. The first was CD10, which was, it was a study in patients with mild to moderate COVID-19. And that's defined as individuals who test positive by PCR. So we know they're infected and they have mild to moderate symptoms, but they don't require oxygen. So if you do what's called an oxygen saturation, an O2 sat, they're above 93%. They maybe have a little cough, maybe a little bit of shortness of breath, but they don't require oxygen. And then CD12 was a study of patients who were on oxygen and or worse. So severe and critical. Yeah, CD10 was in mild to moderate. CD12 was in severe and critical. And severe and critical includes patients on a little bit of oxygen by nasal cannula, so 2-liter flow, or high flow oxygen with a mask, a rebreather mask, or patients critical in the ICU who have a breathing tube in place. And we've learned over time that leronlimab, it doesn't matter how sick you are, that leronlimab can potentially benefit you. So over time, we opened up the criteria to include anybody at any age, however long they've been intubated. Severe, critical, doesn't matter. So we have released this last week, we had a data safety and monitoring committee review the safety of CD12, and they get to see the safety signals, and they have got back to us and said, no problem, keep going. And that CD12 study now has 175 patients enrolled as of today. We are scheduled with the FDA to do an interim analysis when we get to 195, which means we have to enroll 20 more patients. Those individuals have to be followed for an additional 28 days because the primary endpoint in CD12, which is what's called a phase 3 study, so it's a registrational study, the primary endpoint is mortality. So people have to be enrolled, they get randomized to leronlimab or placebo, 2-to-1, and they have to be followed out to week 4. So we expect to have an interim analysis in the CD12 study end of September. In the meantime, we released the results through a press release on Tuesday of this week for CD10, where we have now enrolled 85 or so patients with mild to moderate disease. They again were randomized 2-to-1, drug to placebo, and they were followed out to day 14. And so a much earlier population. And the concern going into it would have been that, is this population too early in the course of their illness to benefit from leronlimab? Because again, it's a drug that is primarily going to impact the chaotic immune response, but people with early illness are not really in the chaos. And so I am stunned to see that even in patients with mild to moderate illness, leronlimab seems to be having a very significant impact and clear signal of activity. And that is the primary endpoint now. In mild to moderate is a phase 2 study, which means the primary endpoints, secondary endpoints are a little less important. Usually you do a phase 2 study to suss out where you're going to be able to move the needle. And then you choose that endpoint and make it your primary endpoint in phase 3. So in phase 2, we set up the study. We're talking about moving things like cough and fever and muscle aches and trouble breathing. And so that's our primary endpoint and a variety of secondary endpoints. And what we saw through the day 14 top line results is that we were able to reduce clinical symptoms of COVID-19 in patients who had a score of 4 or greater at baseline. So you take cough, muscle aches, fever, and dyspnea or trouble breathing, and you assign them a score, or the patients assign them a score 0 through 3. So 0, no fever, 3, I'm burning up. And so they can have a top score of 12. So we found that patients who had a score of at least 4 at day 1, meaning they weren't folks with no symptoms. We had no real effect on patients with no symptoms. Those people tend to get better on their own. But patients who had a score of 4 or more, we reduced symptoms at day 3 from 90% to 70%, which is moving the needle, which is really what you just need. You just need to know that something is real or not. And then, but no p-value on that, which is some people have complained about. But the other thing is that these secondary endpoints did have significant p-values. And specifically, there's a thing called a News2 score, which is a national early warning system score developed by the Royal College of London in England. And it's a score that predicts pulmonary collapse. So who's going to end up being intubated in the ICU? And it includes things like respiratory rate, oxygen saturation, blood pressure, level of consciousness, and so on, 7 metrics. And this News2 is becoming a very critical endpoint in a variety for multiple sponsors. Because what we really, I mean, yes, we want to lower muscle aches, but what we really want to do is prevent people from ending up in the ICU, intubated and dying. And so this News2 predicts who's going to get into trouble. And so if you look at the News2 score on leronlimab versus placebo, we had a statistically significant result at day 3 and day 14. Day 14 was what we would call the intent to treat or modified intent to treat population. That includes every patient who got at least 1 dose of either drug or placebo. And then there's a per protocol population, which is 69 patients who received both doses as they were supposed to. And in the modified intent to treat, we had a significant result with the News2 score at day 14. And in the per protocol population, we had a significant result with News2 at both day 3 and day 14. And then finally, so I've told you that we reduced clinical symptoms in patients that had measurable symptoms at baseline. We've reduced the risk for pulmonary collapse at day 3 and day 14. And then the other unbelievable outcome is that patients are followed for adverse events, bad things that happen. And we reduced those adverse events by, I think it was 50 to 35% or something. But there's also a thing called serious adverse events, which are really bad things that happen, like death, intubation, or other really bad things. And we were able to reduce the SAEs in patients on leronlimab by 64% compared to placebo. So this phase 2 study, which was kind of exploratory, showed reduced symptoms, reduced serious adverse events, reduced risks for severe pulmonary collapse. And we leave CD10, you know, I don't know if leronlimab is a single, a double, a triple, or a home run yet. There's early data that we collected that I haven't told you about from the emergency access patients, 85 patients that were treated through the Right to Use program that suggests the drug is at least a double, probably a triple, and maybe a home run, which is partly why we launched CD10 and CD12. But we conclude from CD10 that there's no question, but that there is a signal that leronlimab is working in COVID-19. It's no longer a question of, is it working? It is. Now the question is, how well is it working? And we are unable to answer that question based on the results from a mild to moderate population, because those folks just aren't sick enough for us to really put the drug to the test. The test will be CD12, where patients are in trouble, and what impact we have on not only symptoms, but mortality. And that will tell us whether this is a double, a triple, or a home run. That was a long answer.
Thank you so much.
No. Yes, thank you so much. I would like to pass on the mic to Will.
Yeah. So you really did give a fantastic description of leronlimab just there. So thank you so much for that very in-depth and eloquent answer. Right now, we kind of just have more of an opinion-based question about the specific racial, ethnic, and socioeconomic impact of COVID-19.
Sure.
And why do you think there are these clear divides and disproportionate impacts on communities of color and low-income communities?
Well, the world has always been such. People with resources have been able to more or less quarantine, more or less, stay at home, have people deliver their food, go on Amazon and deliver their goods, have had the privilege of reducing their exposure to people and hence the virus. People with less resources who are living week to week, paycheck to paycheck, don't have that luxury. And so they've been, glorified as essential workers who are, in the meat packing plants and are working the fields and are being forced to work because they don't have the luxury of the resource to withdraw. And it's, of course, very unfair. It's, of course, disproportionately affecting communities of color. And it is outrageous.
Thank you for your answer. I would like to pass it to Fiza.
So Russia's President Vladimir Putin has registered the first COVID-19 vaccine without going through phase 3 trials. What do you think about this? And why are all these 3 phases of a vaccine trial important?
Yeah. I think the authoritarian regimes, in Brazil, Russia, and the United States have had a very hard time managing the pandemic because management of a problem of this magnitude requires good governance and smart governance. And these folks, in these authoritarian regimes are not there because they're good governors. They're there because they're strong men and able to suppress dissent, control the vote, manipulate media, but has nothing to do with being competent in governance. And so, Putin can claim to have a vaccine, but if it is not tested, it is a meaningless claim. And I would say that there are real concerns about whether we're ever going to have a vaccine. And this would be the bummer part of the talk. If I'm excited that leronlimab is going to be the first drug that actually works to treat COVID-19, I have to also report that I'm somewhat leery and skeptical of whether a vaccine is possible, Russian or otherwise. And the reason for that is that, first of all, there are other coronavirus infections. And what we know is that there are 4 or so that commonly occur and recur every year. And that just because you've had prior infection doesn't protect you from getting reinfected. So that's the biology of coronavirus, is that it comes around every year. And there's no doubt that, in my mind, that some of the determinants of who goes on to have bad disease and who doesn't must reflect in part who's already been exposed and has partial immune responses, specifically T cell responses. So there are two arms to the immune system, antibodies and T cells. And we measure antibodies because it's a lot easier, but probably it's the T cells that are more important, particularly for intracellular pathogens like viruses. But the experiment that nature has done is that you guys get, when you get a cold in the winter, like 1 out of 4 of them is a coronavirus. And then you get over it, and then you get it again the next year. So your prior exposure, while it might mediate the severity of the next illness, it's not protective. And if you look at the antibody responses in patients who've had COVID-19, in folks who have mild infection, some of them aren't even developing an antibody. And the folks with more severe infection, they're developing an antibody, but it's attenuating very quickly over a period of months. And so those immune responses that are being developed in response to the infection do not appear to be particularly long-lived or long-lived, and are inconstant. Now, that said, we're measuring antibodies, and again, it may be that the T cell responses are far more determinative and important. But if you talk about a vaccine, then you're talking about developing something that is going to improve upon what Mother Nature herself is able to do. And we've never really done that before. I mean, there's a reason we don't have an AIDS vaccine. So while I'm hopeful about a vaccine, and I'm particularly hopeful about vaccines that are looking to develop T cell responses as well as antibodies, we have to recognize that that is asking humans to do something that Mother Nature herself has not done, number one. And then number two, so why are phase 1, 2, and 3 studies important? Well, if you're going to show that something's going to work, you have to show that it works. And before you show that it works, you have to show that it's safe. I do think that vaccines are one of the great accomplishments of Western medicine. Obviously pain meds, analgesia, antibiotics, anesthesia, and vaccines are all, I mean, we take it all for granted. But, smallpox has killed more people in the history of the planet than anything else. You don't even have to think about smallpox. Or really, flu. Flu's killed a lot of people. Measles, mumps, you don't worry about them because you've been vaccinated. And the whole vaccine push-pull in our culture, we need a vaccine. It would be a stretch for us to create a vaccine that works in a setting where Mother Nature herself doesn't do it. It has to be a T-cell based vaccine, in my opinion. The recent data in treating people with COVID-19 using convalescent plasma is pretty discouraging. So convalescent plasma is somebody who just got over COVID-19, and then you take their blood and you separate out the antibodies, and then you give them to somebody who's currently sick. It doesn't do them any good. So those antibodies that are being freshly developed in the setting of acute infection don't really help somebody who's now newly infected. That doesn't bode well for vaccines, particularly antibody-based vaccines. So if we're going to have a vaccine, it's going to have to be antibody and T cells. It's going to take somebody smarter than me to figure it out. It's going to have to generate T cell responses that are protective and neutralizing and long-lived. They're going to have to do studies phase 1, 2, and 3 to get the right dose, phase 1. Phase 2, they're going to have to treat some hundreds of people to make sure it's not a harmful vaccine. And then you're going to have to enroll a large phase 3 study, placebo controlled, and then have that population go through a season of COVID-19 to see whether they're protected or not. None of that's happening quickly, and it certainly hasn't happened in Russia. You tell me if I'm being too wordy.
You're good. I'll pass it on to Jason.
Yeah, so we are running a little bit low on time with a good 7 or so minutes. So let's just kind of begin this with a statement. So like according to UCSF from July 12th study, 1 in 3 young adults may face severe COVID-19 with smoking habits predicting COVID-19 progression, more so than conditions like asthma. 31.5% of smokers and non-smokers, which is a larger example, are more vulnerable to COVID-19 compared to 61.1% of just non-smokers, which is a smaller sample.
To
So the
clarify,
question we have for you,
16.1%.
yes. So a question that we will have for you is, would Liramerber help people in our age group from having SAEs related to COVID-19?
What was the question? Would not smoking help you?
So the question is, like, would I'm so sorry,
Leronlimab. Yes.
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 Would that help people?
Yeah. So
Yeah.
So what we know is leronlimab works in COVID-19, and it is utterly amazing that we're doing this interview today, because I can make that statement and I know it's true, and I know it's true for 2 days now. And the world doesn't realize it yet, and we have to break through a lot of media fog, but it is true. And as we see CD12, we'll again know whether it's a single, double, triple, or home run. And then there are questions of, well, where are we going to use it? For example, there are people who are called long haulers who've been infected by the virus, and the virus has gone, the bulk of their symptoms have resolved, but they are still having problems. And there are something like 100,000 people in the country right now who are post-COVID having persistent fevers or headaches or fatigue. And what we don't know is the extent to which that's being cytokine driven. And we don't know the extent to which leronlimab may be able to help them. And we're very quickly trying to launch a study to ask that specific question. The other question is, where are we going to use leronlimab? If there are, it's about 20% of people who end up needing significant medical help with COVID-19. They're generally not the younger folks, but about 20% of the population is going to need medical attention. And that might mean just a little bit of oxygen, or it might mean full-blown ICU care. Where are we going to use? We don't have an endless supply of leronlimab, and there are 7 or 8 billion people on the planet. So we're talking about hundreds of millions of doses that we're going to need, though, which is one reason I've spent the last months trying to get the government and the FDA to pay attention, because we need to ramp up manufacturing very quickly. And then where are you going to use it? Well, the study of CD10 would tell us that if people are, they have COVID, but they don't have a symptom score of 4, there's no benefit. And that we have to wait for people to have at least mild shortness of breath, cough, muscle aches, and fever. But that would mean, I don't know, at least 20% of the Earth's population, or treating like 1.5 billion people. There's not enough drug for that. So we're going to have to hone it down a little bit further. The problem with it is that there are people, if you do a larger study, there are young people who may not have a lot of symptoms, and they may present with a stroke, because again, the hyperinflammation causes clotting, and sometimes those clots show up in the brain. And so it's difficult to know exactly, if we had an unlimited supply of drug, it didn't cost anything, who exactly we would treat with this drug, which is a way of answering that. We don't know yet who we're going to end up treating with leronlimab, but it's at least 10% of the population, and I'm guessing more like 20. And probably depend on the severity of illness.
Thank you so much. That was a really good answer. Now I will pass on the mic to Lisa.
Okay, so how has COVID-19 impacted you emotionally?
Yeah, thank you for that question. This is my third Holocaust. As I said, my mother survived the Holocaust. Her rather large family did not. My mother and grandmother alone. My mother was raised by nuns in a convent in a little village in Poland, who hid her for 6 or 7 years at great peril to themselves. So I was raised in a Holocaust household. And then coming to San Francisco in the 80s, that's Holocaust number 2. And there were thousands of young people, gay, straight, male, female, that I watched die from HIV. And I, you know, that gave me PTSD for sure. And these last 5 months have been really utterly awful. And I know I have PTSD from it. And in part, it's awful because we didn't go into this in detail, but we actually knew leronlimab was working back in March because there were various doctors and families around the country who called and said they wanted emergency access to leronlimab through the Right to Try program. And so the FDA issued individual investigational new drug approvals for about 85 patients who were then treated at various hospitals around the country, in New York, in Georgia, in Los Angeles. And we were able to collect data on those patients. And we Cytidine knew that the drug was working back in March and certainly in April. And we knew it was working before we knew how it was working. And we certainly knew it was working before everybody started dying, and there wasn't any way to break through the media, the government, the FDA, because nobody believed us, because there are 100 companies out there saying, hey, we have the cure to COVID. But we knew we did, and not necessarily the cure, but we had an effective treatment, because even though these were not randomized patients, normally you have to do a randomized study in order to remove hidden biases so that your treatment and placebo groups are balanced for things that you know about and things that you don't know about. Well, we didn't have a randomized control arm, but we were treating the patients who were on death's door. So there wasn't a lot of randomization bias. If anything, we were treating the sickest of the sick. And a lot of these folks died. But we looked at their lab results, and before they died, they were able to show us that the drug was working, in that we saw reduced levels of the cytokine IL-6. We saw increases in the CD8 counts and balancing of the immune system. And so there were a bunch of people who died, and the last thing they did before they died was show us at Cytidine that the drug was working. But nobody would believe that data because it wasn't really randomized data, and nobody acts on data without a control arm. So we have had to hustle to get the CD10 study, the CD12 study first approved by the FDA, and then we had to get them enrolled, which was incredibly difficult in an environment where Gilead and other large companies, Roche, Genentech, were doing their own clinical studies, and just had far more resources than this little company, Cytidine, which started as a nickel 30-cent stock. They just didn't have the money to throw at this the way a big company would, and certainly NIH and our government. Nobody has helped Cytidine with anything. So it was extremely traumatizing to to look at the results from the emergency IND patients, be pretty sure we had a treatment that was working, even in patients who were really ill, and then to then even not even know exactly how it was working, which cells it was affecting, trafficking, but then to have to start from scratch while we're hearing reports like there are not enough ventilators in New York, and then to see 150, probably closer to 200,000 people now die, and just in the U.S. While we've been scrambling to get these studies filled, enrolled, and then now analyzed, it has been psychologically and spiritually exhausting. And there's really nobody in a position of any authority that has helped us at all. And I'm trying not to be bitter about it.
Okay, thank you. Do you have any closing remarks for us today?
I just say thank you. I enjoyed talking with you. I'm sure I ran on more than you anticipated, certainly more than I anticipated. It's incredible that you asked to do this interview this day. One thing I've learned about COVID is I've had to learn to trust the process. There's a hand in the universe, Mama Gaia, she's got it. Things are happening for a reason. Sometimes we don't understand why. And I actually want you to know, it means a lot that we did this interview today, because these feelings that I'm having, this information that I'm sharing is both raw and fresh. We've submitted to the FDA now, and we're submitting to the regulatory authorities in England, in Mexico, Brazil, hopefully Israel. And you are about to hear more about leronlimab in the coming weeks and or month, 6 weeks, CD12, certainly by October 1st, hopefully. But no one right now knows about it except you and me and a few other people and Cytodyne's investors. So it's incredible that we've had this opportunity. And I'm grateful to have had this opportunity to share this with all of you. Thank you.
Thank you, guys. Thank you for taking your time to speak with us today.
Thank you so much.
Thank you so much, Jay.
You bet, guys.
Thank you.